Hello, good morning everyone.
On the current reviews and studies in the literature on MDMA, enhanced psychotherapy in PTSD. I struck the ecstasy away because I don't think that it really represents the pure MDMA. And I have to be honest, because this is a very new subject to me. When I saw that I need to tell about it, first I was like, okay. And after reading the literature, I really got excited, especially as a person who works on PTSD patients. This new approach excited me. And I think, I know as some of you are also like to think out of the box, I hope you will also get excited. So I used a few review articles which are published in Frontiers in Psychiatry. This is from Lancet Psychiatry. And another Lancet Psychiatry article about a randomized double-blind dose-response phase 2 clinical trial. So what is MDMA? It's the central nervous system stimulant that falls under class 1 stimulant group. Yesterday I talked about class 1 groups. Those are considered as hard drugs. The common effects of MDMA come from its ability to bind the strongest to serotonin transporters, inducing a speedy release of serotonin and dopamine. Multiple receptors, neurotransmitters, and intermediary processes probably account for MDMA's effect. So it mainly acts as a releaser of serotonin and noradrenaline, and to a lesser extent also of dopamine. While typical effects of MDMA can be predominantly attributed to the activation of the 5-HT system. Here you can see those neurotransmitters and hormones correlation, and we see serotonin, norepinephrine, dopamine, oxytocin, what a psychiatrist would like. Everything we see here, and I'll come back to the slides later on. Activity of the 5-HT receptors weakens the feelings of depression and anxiety. It reduces the amygdala fear response and increases the levels of self-confidence. So this is primarily serotonergic, but also affects as norepinephrine and dopamine. Enters presynaptic cell via monoamine transporters, acts as a weak 5-HT, causes indirect oxytocin secretion, and inhibits rate-limiting enzyme for 5-HT synthesis. Well, this will create increased feelings of closeness, great compassion, increased empathy, in the language of psychiatry, for oneself and others, which will contribute to the positive mood. Increased dopamine and noradrenaline raise levels of arousal and awareness. MDMA's effects at alpha-2 receptors, which contribute to the drug's effect on thermoregulation, may also contribute a paradoxical relaxation, which could be beneficial in the context of trauma-induced hypervigilance. So in that sense, we could talk about therapeutic effects. Increased oxytocin levels, we are talking here, decrease in amygdala activity, which decreases the fear and avoidance, what we see in PTSD and traumatic patients. Increase in norepinephrine and cortisol, that facilitates the emotional engagement. So this release of oxytocin, which are related with early infantile bonding, that increases again the empathy, closeness, and damps the fear-related amygdala activity, which would cause a decrease in stress response and social anxiety. Toxicity in recreational users. Well, it's unfortunately, as an ecstasy, could be used in parties and recreational use. So again, I will be very cautious not to confuse it with MDMA, pure MDMA versus ecstasy. But here, the toxicity from the ecstasy I'm talking about, there are rare cases that are reported. Also in animal studies, we see that there are high doses and moderate abuse potential it has. But clinical MDMA, this is incomparable with the recreational in terms of drug purity, administration, and screening and monitoring. So because of this association of MDMA and ecstasy, unfortunately, the drug has not had the chance to further research, and that affects the fundings as well. So the history of MDMA, 1912, Anton Köllisch from the Merck Pharmaceuticals synthesized it for the first time. 1976 was the first report of the psychotropic effects in humans. And they wanted to keep it like that, actually, clinically used, empathy-based research community, in the research community. But unfortunately, it has been started to be marketed as ecstasy in those times, after 76. And then DEA banned it at 85 as a class 1 drug. And now, after 2010, MAPS organization, this is the Multidisciplinary Association for Psychedelic Studies, they are spearheading global clinical research on MDMA. I will tell more about it because now they are in their clinical phase 3, which is a great success. I try to be not too enthusiastic about this and not give you the impression as I am promoting it, but its literature shows very positive effects of it. Again, Greer and Tolbert looked at MDMA-assisted psychotherapy from 1998 to 1985. They collected 80 patients, they screened the criteria, and they found out that it checks all the boxes of PTSD, actually. Re-experiencing flashbacks, intrusive memories, nightmares, avoidance, external and internal numbing. Many of us, with our patients, we witnessed that, unfortunately. Hyperarousal, anxiety, sleep problems, increased startle, and some people, most of them actually, have some sort of dissociation. So why PTSD and MDA? Well, it comes from the definition of PTSD. As a psychiatrist, when I sit on a table with a chemist, with a pharmacist, I will ask her, him, help my patients with fear, with defensiveness, lack of trust, bonding, memories, sleep, and that's why this correlation. Animal studies have demonstrated MDMA increases fear extinction through a mechanism dependent on elevated levels of BDNF, brain-derived neurotropic factor, in the amygdala, which might account for the observed phenomenon for MDMA. Well, it's usually avoided, this painful memories are avoided by our PTSD patients due to the overwhelming negative effect. So when we have our patients in our therapy room, it doesn't matter how talented we are with our psychotherapic talents or the medication, but we can't get the patient to those horrifying memories, 50% of them I'm talking about. So 50% can benefit, but the other 50% cannot get back to those memories. So here we need something that can help them to relax and not afraid, like a life jacket they will put on to go further with the therapy. And this is why PTSD and MDMA. Although advances in psychopharmacology during the past 60 years has benefited millions of patients of us with the psychiatric disorders. However, approved psychopharmacological drugs have fallen short in correcting underlying the pathology, so curing the psychiatric disease. Antipsychotics, antidepressants, anxiety, mood disorders, mood stabilizers, they help to decrease the symptoms and can even be life-saving for some patients. But benefits are sometimes disappointing and the side effects could be long-term. So our patients deserve other chances. Well, advances in evidence-based psychotherapy have yielded also improved treatments for several disorders, including PTSD and anxiety. They seem to be even sometimes more effective than the medical treatments. But again, large percentage of our patients don't respond to those therapies as well. So in our experience as therapists, we see the suffering and frustration of our patients. They don't have a relief. And They use several drugs, drug after another drug. It's not working. We use different types of psychotherapy modalities. It goes for years and years, and you know the scenario. I think that created a psychiatrist's identity crisis. We are suffering with them. I will give a description of a phase 2 clinical trial from the literature. So they gave MDMA together with psychotherapy, and they found out that it can be safely administered. Again, the reasons they studied it for was fear, defensiveness. Their protocol was double-blind placebo pilot study of treatment for the resistant crime or war-related PTSD. Their design was 20 subjects with PTSD, male, female, crime or war-related. And 60% received MDMA, 40% was placebo. Patients stayed there overnight, and they got a dose of 125 milligram followed with 62 milligram. I honestly don't know the right dose about it. We never tried it in our clinic. So they continued to screen, and in outcome psychologists were not involved. It was 2 psychiatrists doing this research. An inclusion criteria was PTSD, may have a mood or anxiety disorder, crime-related PTSD, rape, assault, and a therapy-resistant PTSD. Exclusion criteria was obviously pregnancy, psychotic disorders, bipolar A, dissociative identity, borderline eating disorders, and other physical disorders, and risk of re-traumatization, suicide, and hospitalization. There have been 17 visits after informed consent meetings. I'm passing this quickly because I could give all the references later on to you. For me, the results part I would like to come. So in APA guidelines, they saw that because there's a paucity of high-quality evidence-based studies of interventions for patients with treatment-resistant PTSD, that cannot be addressed algorithmically. So there are limited data to guide the clinician in the treatment of patients with therapy-resistant PTSD. They got, in this study group, they had a comorbidity, but as I say, they included the bipolar, the unipolar depression, panic disorder, the STIMI. And in the placebos, they had the same, similar. So after 7 days, there were side effects. Anxiety, fatigue, headache, heavy legs, as you see in the list, restlessness, thirst. Seems like a long list, but when I look at the paracetamol or aspirin side effects, I see also like. In the placebo group, there was also anxiety, fatigue, headache, increased irritability, low mood, insomnia. Those are 2 psychiatrists that gave psychiatric nurse, and there is a psychiatrist assisting these therapies. Their approach was based on Stanislav Grof. I don't know if any here knows about Grof, but he's a psychiatrist who worked about psychedelics and psychiatry. It was non-directive psychotherapy they used, supporting. I watched the videos. I was so curious how they do it. They are really close to the patient, and patient is there on MDMA, and patient is going through all the stages, and the therapist is there really for her. It's very much different than laying on a couch from a distance. I'm not criticizing psychoanalysis, but this was real contact, what I've seen in the videos. The emphasis on experience, emotions, and somatic symptoms, rather than avoiding or suppressing, was at the settings. Obviously, they prepared for the settings, and they followed up for the integration. So for the measures, they took the CAPS, Impact Event Scale, CSSCL. So this is the difference. In the end, they made analysis. They found out that CAPS score MDMA group versus the final group. pre and post. As you see the difference. And then so is for the IES, and so is for the SCL. And don't forget, it's for 20 patients, so I really wonder if you do it on thousands of patients, what would it look like? After 3 months, there was a big difference. For stage 2, after 3 months also, pre and post MDMA. And what happened? What did they tell these patients when they were there on the couch together with the therapist? Well, it was challenging as well. It was not all like blooming flowers. They were scared. They had strong feelings of fear, deep sadness. They were afraid, like the first patient describes it. He felt very much anger, sadness, loneliness, which are very known feelings actually. But if you have a PTSD patient, it's very hard to hear it so intense from them. And the second patient described as more clearly how limited and problematic their relationships. So you see it also here. First and second quotes, sometimes after the MDMA has worn off, people may have doubts about whether it was really okay, or to talk about some of what come up in the session, or may have fears of being judged, or old message in mind that it's not safe to reveal secrets, or self-judgment and shame that they have never been admitted before. But as therapists, we know how important it is to admit for our patients. There starts the therapy. And the third quote, I'm still struck by the deep realization. So that illustrates an experience that a number of the subjects have had. They felt like they woke up after years of being asleep or in a trance. How many times in our lifetimes we have such feelings or thoughts? We kind of live in the automatic state, especially busy people, and then something happens, and once in a lifetime, then we're like, oh yeah, I'm alive. I think that's what they had here. So they also start to work on with acceptation. After the stage of fear and confusion, they came to accept. In one session, this is happening. So she says, I have respect for my emotions now. What's most comforting is knowing now I can handle difficult feelings without being overwhelmed. I realize feeling the fear and anger. It's not a big deal. Being able to feel again is indescribable. So almost like when you feel, you can heal. So if people have support in working with the challenges that come up, not only do they realize they don't have to be afraid of being overwhelmed by their emotions, they experience the value of not numbing themselves from their emotions and being able to share their feelings with other people. With that comes a much richer way of experiencing life. Being numb is not the issue there anymore. So, yes, integration was the last phase of it. It was very difficult as well because you put someone to a state that has not been there maybe ever in their life, wake-up state we call it, and then how to handle it afterwards. It can be hard to predict because those people are also victims. They have been abused, they have been in wars, they have been raped. So they have been followed up for that. They all talked about the nature and depth of their healing experience. Some said that I have a map of this battlefield. Some said I was deeply connected to painful feelings of traumas. A whole deeper level of consciousness, calm, glimpse of more what I am capable of doing. I can feel my body without having to make reference to the attack. My body is more than a victim. Here you see the self-confidence of saying it. I had a clear sense of where I have to be. It wasn't an easy experience, but it was a very expensive one. I have calmed and stability now. Greater connection. Some of them said after 3 weeks, after the second MDMA session, they told that without the study, I don't think I could have ever dug down deep. It felt like growing up. Isn't it so when we have these adults in our rooms? Sometimes I have the feeling like as if it's a child sitting there. So this person had the feeling of growing up. So what was the benefits? Well, after the study, they concluded like enhances psychotherapy not taking as ongoing medication, desirable effects on brain activity, neurochemistry, and hormones, positive risk. So MDMA is showing encouraging results from their study as a treatment for refractory post-traumatic stress disorder, social anxiety in adults. This is not only their study, but with the review, I should correct. Anxiety-associated life-threatening illnesses, such as adjuncts to psychotherapy, rather than standalone medicine. So I have to emphasize, I'm not telling to use the MDMA as one pill. I'm talking about psychotherapy here. It's something to assist psychotherapy. So it shouldn't be taught as, okay, here is the MDMA and this person will... No, psychotherapy is the big part of it. So this is drug-assisted psychotherapy. Well, as we talked, common side effects, decreased concentration, jaw clenching, dizziness, dry mouth, feeling cold, impaired balance, anxiety. And it was common with the placebo group as well, anxiety, drowsiness, insomnia. This is a US pilot, and she is describing MDMA therapy that she had. She was also in that study. Another person who turned back to functioning, Asperger. So therapeutic potential seems like, as far as I read from the literature, we could search if we can use this therapy method in sexual assault, war, violent crimes. But it's not a classic psychedelic drug, is it? It's an entactogen, which creates closeness to others, empathy, well-being, insightfulness, less perceived loss of control. Might be fitting drug for trauma-related psychotherapy. Might. In summary, the combined pharmacological effects of MDMA and the associative subjective psychological experience provide a unique selective impairment of the fear response while leaving the other faculties intact. So as I described before, as a clinician, if I'm sitting with a person who will prepare this medicine for us, it checks all the boxes. Therapeutic benefits, again, help down the boundaries in communication. That helps with the patients who are aggressive, defensive, unwilling to open up, increased feelings of empathy, acceptance, feelings of tranquility and peace. Deeper personalization, there I will be very careful. I wouldn't, and they didn't as well in the studies, I wouldn't give this medicine to someone who has psychotic tendencies or has a history. The chance of psychological dependence should be very well evaluated. And there are possible adverse effects as well. Increased body temperature, heart rate, blood pressure, muscle tension. Impairment of episodic and working memories and attention is something should be searched more into. This is my critics for those studies. So, again, as a sum, it seems like it decreases the fear response, leads to corrective emotional experience, diminishes the pathological effects of previous traumatic experiences, effective skills for communicating feelings to family members. This is what was reported from those studies. And those benefits were lasting up to 2 years follow-up for most patients. I'm very curious, if you follow them up for 10 years, what will come up. So this is what they're right now doing, actually. So MAPS is a very important name here because it's a multidisciplinary association for psychedelic studies. When everything was banned, they took it over, and they are now in the phase 3 trials. So far, 2 phase 2 trials tested MDMA-assisted psychotherapy for treatment resistance, and they are completed. And they had this encouraging results so that they could go to the phase 3. And as you might know, phase 3 studies involved randomized blind testing in several hundred of several thousand patients. And the benefits will be looked. And it's also known that 70 to 90% of drugs that enter phase 3 successfully complete this phase and testing, which means that we should be very aware. 2021, the studies will be all completed. Then a pharmaceutical company can request FDA approval for marketing the drug. This is Stan Groh. He's saying psychedelics used responsibly and with proper caution would be, for psychiatry, what the microscope is the biology and medicine. Thank you for your attention. I would still like to emphasize, I read the articles and the literature, and that excited me, but that doesn't mean that it's complete. 2021, we will have the end results of the studies. But what excites me is to think again out of the box and give a chance to our patients, because they are suffering, and we see that, and we are helpless by not helping them. We should stop helping the symptoms. We should really go to the core of the psychopathology and try to find a way to treat them. Whether it is X or Y, we should just have the open mind to accept the chance to go to the research, not of course immediately to the markets, but to search into if it is possible. Thank you.